Hi everyone, I'm Michelle Coombs. I'm a physical therapist, and today I'm really excited to talk to you guys about visual rehabilitation. This is something that I've taken additional courses in, gotten a certification in, and I've used it so many times, and I found it to be really helpful in my previous work settings. Visual rehab is useful for people who have lost some sort of visual function, people who have sustained a brain injury, whether it's mild like a concussion or something more severe. Some people have a neurological condition, such as a brain tumor or a stroke, or even if they just have low vision. Visual rehab is something that's pretty unfamiliar to most people, but if you work with certain populations, especially those with neurological conditions, it is extremely helpful to be aware of. In fact, over 85% of people who have a stroke have some sort of visual deficit and would benefit from visual rehab. It's a very specialized type of rehab and requires team effort, usually with the physiatrist, the physical and occupational therapist trained in visual rehab, as well as the neuro-optometrist and maybe even the neuro-ophthalmologist. The goal of visual rehab is to maximize whatever vision is left, restore function, and improve participation in activities they love and improve their quality of life. We know that through neuroplasticity, we can retrain visual processing pathways through exercise, adaptation, and sometimes, if needed, compensation. This video is not going to cover specific exercises, but rather concepts and the treatment hierarchy from a rehab therapist perspective. As always, we want to have a good subjective. I want to know if they wear glasses, what kind of glasses they are. Are they for reading, distance? Are they progressive glasses? Many people are unaware that progressive glasses, if you've had a neurological event, can actually impair your balance because it tends to distort or blur the floor. I would want to know if someone has had previous eye surgeries or premorbid eye conditions, and if they have had a neurological event, have they noticed any changes to their vision since the event? This may include dizziness, difficulty reading, words jumping around on the page, feeling overwhelmed by crowded areas. They might experience double vision or light sensitivity. Again, these are all very important things that I would want to know and might give me a hint on what deficits might be present. Now, to get into the hierarchy or order of treatment, these are general guidelines and considerations that we should take when we're dealing with someone who needs visual rehabilitation. First, I want to ensure optical correction. So this means if they have glasses, are they the right prescription? If it's not the right prescription, it may warrant an optometry referral. Next, if someone is experiencing double vision, that's a condition that's extremely frustrating for the brain. People will tend to close their eye or cover up one eye. Over time, the brain may even start to suppress that eye, and that's called suppression. That's something that we do not want. Sometimes I'll see people put on an opaque eye patch. This is really more of a last resort. If I completely patch that eye, I'm stopping any input or stimulus from that eye to the brain. We could argue that that might even encourage suppression to occur. A better option would be to use some sort of translucent patch, maybe using transport tape and placing that patch somewhere on their glasses, wherever is appropriate, to eliminate that double vision early on and allow them to participate in their visual rehab exercises. Next, we want to consider monocular training if it's needed, so training one eye at a time. We want to make sure that the success level of these initial tasks is high. There's probably nothing more discouraging for someone than to be failing basic eye tests, and we want to build up that confidence early on. Next, we'll look at ocular motility, or the ability of the eye to perform basic movements. We want to ensure full range of motion and that they can perform smooth pursuits and saccades. A smooth pursuit is the ability of the eyes to follow a moving target, and the saccades are the ability of the eyes to jump back and forth between two targets or from one target to another perfectly. Next, we'll consider binocular vision training, so using the eyes together. If I am using this pen and I'm bringing it closer to my face, my eyes have to turn inward at the same degrees at the same time in order to keep my vision focused on that pen and to keep it singular. If there is any difference in the way one eye is coordinated with the other, then I might see double or two images instead. It would also be appropriate here to work on accommodation. Accommodation is usually the measure of one eye's ability to shift its focus from something that is near to far or far to near. Next, we would want to eliminate any head movements with ocular movements. So if I'm looking at this pen and it's just moving back and forth, I should be able to keep my eyes on that without moving my head. Unless the pen goes somewhere outside of my visual field, I may have to turn my head to look at it. But other than that, there shouldn't be any extra head movements. We find that in people who have visual deficits, they tend to move their head even when it's not really needed. This is also a point where we can start to add in some cognitive, motor, and balance complexity. So I could have somebody look in a room for red-colored objects while they are walking into the room. This could potentially simulate walking down the aisle of, let's say, a movie theater, and they're looking around for their family member who's wearing a red shirt. Last, we would work on fusional vergence, which is just a measure of the ability for both eyes, the image from this eye and the image from this eye. They're going to be slightly different because of the position of the eye on the face, but it's the ability for the images to fuse together to make one singular image. Here we would also work on visual processing, visual perception, and keep in mind these are all advanced exercises. A lot of the time is going to be spent making sure we have the fundamentals, so the things that I listed before. For the visual assessment itself, many times I'm sitting in front of the person and I have a target stick. I usually use a popsicle stick and I draw maybe a little H or a little A on one end, and that's their target that they have to look at or fixate on. But I want the background behind me to be blank and bare. I don't want a bunch of clutter. I don't want a bunch of distractions. That's going to affect how they perform on these tests. If they have their glasses, I want them on for the test, and I want to test each eye separately before testing both for most of these tests. First, I would look at their acuity. So if you've been to the optometrist's office, we can use the same charts, a Snellen chart, a distance chart. If they have trouble distinguishing letters, then we can use the falling E's chart, which they would just indicate what direction the prongs of the E are pointing. Next, we'll look at contrast sensitivity. Now, contrast sensitivity is actually more functional than acuity. If I can't tell where one stair ends and another begins, then I'm going to be more at risk for falls. Normally, I look at this using the Pelley-Robson chart. Next, I'm going to look at confrontation testing. So this tests our visual fields. We want to make sure that no part of the visual field is missing. Sometimes that will happen if there's been damage to the optic nerve or somewhere along that nerve's path to the brain or the area in the brain responsible for visual processing. Next, we'll look at cardinal gaze. We want to check all 9 quadrants and make sure there's no range of motion limitations in any direction. Then we'll look at smooth pursuits. I generally use the popsicle stick and I move in 5 circles in each direction, going from small to large circles, and I just make note of the movement quality. Is it jerky? Is it cogwheel-like? Are there any losses of fixation, etc.? Then I want to look at saccades. So this is, again, the ability for eyes to jump from one target to another. We need to make sure that their eyes are not overshooting or undershooting the target. We want them to be able to perform these in horizontal, vertical, and diagonal dimensions. This is very functional because we actually use saccades when we're reading. Next, we'll look at something called the near point of convergence. This is just the closest point at which both of your eyes can work together to maintain one single image of a target. So normally, if I'm bringing this pen closer to my face, there's a point about 6 to 8 inches from my nose where it is normal for that image to split into 2 images. That's normal. If that split occurs further away from my nose, it means that my eyes are not coordinating together to maintain a single image. Something is impaired there. Next, we'll look at accommodation. Accommodation is the ability of the eyes to adjust their focus on something from near to far or far to near, like we mentioned before. Now, this is not really relevant to assess in anyone that's over 40 years old. A natural part of aging is that the lens in your eye is going to stiffen, and the muscles that are responsible for changing the shape of that lens, they also kind of lose their tension. And so in the younger population, if this is something that is impaired, it's definitely appropriate to work on, but not really for people that are over 40. If you test this, they're going to be impaired. And that's just a natural part of aging. Last, I usually take a look at some various eye cover tests. This just tells me if there's atropia or aphoria present. Those are fancy words, but they just mean misalignment of the eye. So depending on whether that misalignment is constant or only occurs when fixation is broken, such as when I cover one eye, that's going to tell me if there is atropia or aphoria. Now, I know we went over a lot of information. This is really just an overview of what visual rehabilitation might entail. It's important to remember that there's an order or hierarchy in which you would treat. So before I can really think about training visual perception, I need to make sure that their glasses are the right prescription, that their eyes can perform basic movements, and that they can use their eyes together. Those are some fundamentals that I need before more advanced training. Again, this requires specialized training, usually through courses or certifications, but it's a fascinating area. It's definitely underappreciated, but has a big impact on someone's quality of life. All right, I hope you enjoyed the video. If you did, like it and subscribe. See you next time.